Now starting. All attendees are in listen-only mode.
Good afternoon, everyone, and welcome to our webinar this afternoon and discussion. My name is Scott Wolf. I'm the Executive Director of the Canadian Association of Community Health Centres based in Toronto. Joined by a board member from the British Columbia Association of Community Health Centres and our presenter today, Valerie Castex. Before I hand it over to them, just a couple of housekeeping bits of information. We're going to ask people to please hold questions until we get to the Q&A section of the discussion today. We anticipate that the presentation will take somewhere between 45 minutes to an hour, allowing for at least 30 minutes for questions. When it gets to that point, you have two options. One is to click on the little hand symbol in your user dashboard for the webinar platform, and I can unmute you and you can ask your question, or there's a questions panel in that platform as well. Feel free to type out the questions and we can read them out for you at that point. So we're very happy to be co-hosting this session for you today with our partners at the British Columbia Association of Community Health Centres. And we're joined by one of BCACHC's board members, Piotr Maszkowski, who's also a board member at the Reach Community Health Centre in Vancouver, British Columbia. I'm going to hand over to Piotr and he'll introduce Valerie and get us started. So over to you, Piotr.
Thank you very much, Scott. So good morning to all those folks listening in Vancouver or BC, and good afternoon to those listening further east. We're coming to you, both Valerie and I, from unceded Coast Salish and Stolo territory here in the Lower Mainland of British Columbia. In my other life, in addition to representing BCACHC to you today, I also teach nursing at Douglas College, and I have the honor of normally working right next door when we don't have physical distancing measures in place to Valerie Castex. Valerie is a registered nurse. She's worked in intensive care for 10 years. She's a master's of epidemiology from the University of British Columbia. She's worked as the Infection Control Program Manager with the Fraser Health Authority, where she's worked to develop infection control guidelines, as well as respiratory outbreak protocols. Valerie's been involved in numerous projects over the years, too many to list, but I'll highlight for you that she's worked with the Saudi Hospital Review to mitigate the transmission of the MERS coronavirus, as well as having developed an entire N95 training and fitting program. In our faculty, she's an absolute expert in infection control, and I would very much like to welcome Valerie to the call. Thank you.
Thank you so much, Piotr, and thank you so much for inviting me to speak to everyone. I'm very honored to speak to some of the frontline people working in this pandemic, and right now I am actually working from home, so I feel very much indebted to all of you. So in this discussion, I will be talking about respiratory outbreaks and pandemics and what I know about them. And following this, I'll be showing you some resources that should be helpful in determining how to problem solve issues surrounding infection control and scarcity of resources during a pandemic. So Scott, I don't see the slides. I'm not sure which slide we're on. Can you help me with that?
Sorry, Valerie, you don't see them on your screen?
I don't see them on my screen at all. So it makes it difficult to say what slide to move forward to.
Okay, you logged. Did you logged in using the webinar platform, the visual one?
Well, I logged in. It says go to webinar control panel. I've got that, but all I see is infection control and community centers, but I don't actually see my slides anywhere.
Okay, one moment.
Sorry about that.
No, one moment, folks. Are you seeing it now?
Oh, there we go. Yes, I do.
My apologies. Yes. That was a controller error on my part. Carry on.
Thank you so much. So what do we actually know about pandemics? Next slide. Next slide. Okay, excellent. There you go. So, well, what we know is that there have been a lot of pandemics throughout history, and many of them are linked to overcrowding and poor living conditions. Respiratory viruses have definitely caused most of the outbreaks that spread quickly, although, of course, we couldn't do any genetic testing or any actual testing, well, just a few years ago. But what it seems like is that only 2 major airborne bacterial outbreaks have actually occurred over the past few centuries, one of them being the Black Plague, killing approximately 200 million people at the end of the around the 14th century, and active pulmonary TB killing approximately a quarter of the European population. As you can see from this picture, though, in recent history, we've had quite a few close calls with small outbreaks and pandemics. Some of these have actually been caused by the coronavirus. Next slide. Next. There we go. So the organism we have focused on as the probable cause of a major pandemic that we've been planning for quite a long time in epidemiology and with the Ministry of Health is a pandemic caused by the influenza virus. So therefore, all of the guidelines that you will see when you research things for pandemics and pandemic planning in the entire world have been focused really on the influenza virus. It's a dangerous organism because it kills approximately 1 in 1,000 cases every year because it has become now endemic to many countries of the world. We're able to track it and create yearly vaccines for the most likely circulating strains, as you all know, but we're never able to eradicate it or to protect ourselves well from infection because it contains 8 segments of RNA, and RNA viruses are actually very, very prone to making lots of mistakes and errors as they recombine. And because there's no error checking mechanism with RNA viruses, they're able to actually create enough variability and variation over time that there's a lot of drift in the recombinations and the types of viruses that are circulating on any given year. Next slide. An even more concerning issue with influenza is that the type A of the virus has many natural hosts other than humans. And as you can see from the arrows in the picture on the right of the screen, the strains that infect avian and swine species are of particular concern. The ability of the avian and swine subtypes to infect humans occurs through a process called antigenic shift. I heard a child. Through a viral mutation, some avian subtypes are able to infect all other species, including humans and swine, and many wild birds are asymptomatic carriers of influenza and are able to spread it over vast distances to domestic avian species, to swine and to humans. Some avian influenza subtypes, such as H5 or H7 subtypes, are deemed to be highly pathogenic as well and have a very high mortality rate. And when these subtypes are able to be transmitted effectively human to human, they have the potential to cause a serious pandemic. Also, the swine species are an even bigger concern because they can be infected not only by the influenza strains, human swine influenza strains, but also humans and avian strains. So they become a perfect mixing vessel for influenza through genetic reassortment of the viral RNA. And so therefore you can get the highly pathogenic subtypes that are avian species that can be easily transmitted human to human by mixing in the swine species. So I mentioned this because, of course, what we're finding is that the coronavirus, although we hadn't become very acutely aware of it, is able to infect also many other species of animals. And because of that, and some of these species are potentially good mixing vessels as well, and therefore can get infected by human strains as well as zoonotic strains. So next slide. So how does a pandemic begin? Well, areas where birds, pigs, other wild animals, and humans live in close proximity are definitely high-risk environments for entogenic drift and shift. And so therefore, most of the species that we get on a yearly basis for influenza, but also the ones that occur and that humans are actually have no immunity to, come directly from animals, usually come from areas where there are many animals and humans that live in close proximity. Next slide. Currently, we're at phase 6 of the World Health Organization pandemic phases. And as you can see from this table, there are usually further pandemic waves that can be expected after the first wave. And currently we're just on the uprise, and as far as we know, we haven't reached any peak for this first wave. Next slide. When we look at the epidemiologic curves of pandemics in the past, this one is from 1918, you can see that it has 3 waves. And also, as you can see from this graph, the second wave is often more dangerous than the first. This can be due to low levels of viral transmissions or asymptomatic cases that continue to circulate in society, even while we have social distancing measures. And after the measures have been removed, then you get a sudden spike in transmissions and in cases. Next slide. So as I mentioned, over the last couple of decades, a virus that previously only seemed to cause the common cold is now causing a lot of trouble by having many subtypes jump from animals to humans. The coronavirus caused the SARS outbreak in 2003 with a 10% mortality, but caused less than 1,000 deaths. MERS-CoV started in 2012 with a 35% mortality and caused less than 1,000 deaths. And now we have COVID-19 with less than 4% mortality. And in fact, that 4% mortality might seem like, well, it's a lot better than the 10% and 35%, but the Spanish flu that killed approximately 40 to 50 million people had a mortality rate that was approximately 2%. Next slide. So what are the clinical features that are very, very important to keep in mind and that we've learned so far from this coronavirus? Although it's a novel virus, it's behaving quite differently from the influenza virus. And so what's important is to actually know what the differences are. And some of these differences will be a benefit to being able to control the outbreak of the pandemic. And some of these differences will make it more difficult. This virus, as we know, behaves even slightly differently from the SARS virus and the MERS-CoV virus. But they definitely have more similarities with SARS and MERS-CoV than with influenza outbreaks. So we know that the incubation period is from 1 to 14 days, and that is probably one of the biggest issues with this particular virus, with a mean incubation period of 5 days before a person would show symptoms. In fact, I was reading this morning about Iceland and how they found so far that approximately, as they were doing random testing of the population, they found approximately 50% of the cases were completely asymptomatic. There is a sudden onset of fever and cough, and the person may also have some fatigue, myalgia, respiratory symptoms, etc. What's very different from influenza is when there is its highest viral load. And actually, this is working definitely in the favor of being able to control the outbreak more effectively than if it had been caused by an influenza virus. Because we know that the viral shedding seems to occur mostly during the symptomatic period rather than the asymptomatic period. There is some viral shedding when the person is asymptomatic, but definitely a higher viral load and more shedding during the symptomatic period. We know that there's peak viral shedding that's delayed and is more highly concentrated with increased respiratory secretions. We also know that children do not seem to be causing that many transmissions. They may end up being positive when they're tested, but they haven't been found to be the cause of many transmissions. They also don't have that many symptoms. However, we know that the virus can remain alive on surfaces for hours to days. We know that approximately 80% of the cases are mild or asymptomatic, and 15% are severe, and 5% are critical. And we know also that the population at risk is with older adults and people who have comorbidities. And that's quite different from a pandemic flu, which usually causes more illness in the young and young adults and young children. All right, next slide. So given this information, what can be done to prevent the spread of infection in community clinics? Next slide. So based on contact tracing for cases of COVID-19 since the beginning of the pandemic, we know that most transmissions are linked to close, direct, unprotected contact with symptomatic cases. There's some evidence of transmission via the eyes from cases who were wearing N95s, but no eye protection. But these cases mostly occurred with SARS, and so far, I'm not sure that they actually have found any cases for COVID-19. So far, there is no evidence for airborne transmission for people who remain outside of the 2-meter range, and yet the transmission still occurred, especially while wearing personal protective equipment. And studies that were conducted in a lab environment have shown that aerosol generating procedures can cause the coronavirus to become airborne. For this reason alone, N95 respirators have been recommended for use during these types of procedures and should be worn for a few hours in that room after the procedure is complete. We also know that because the coronavirus can survive on surfaces, then it makes sense to see all fomites and objects around a symptomatic case and being touched by a symptomatic case as possible sources of infection. Next slide. So just to remind everyone of what aerosol generating procedures are, there are procedures that usually interfere with the airway and cause changes in the pressures of the airway. And so procedures such as using BiPAP or CPAP, doing an endotracheal intubation, airway suctioning, doing a tracheostomy, doing a sputum induction, chest physio, using aerosolizing mechanisms such as nebulizers, doing a bronchoscopy or an autopsy of lung tissue, or using high-frequency oscillatory ventilation. All of these methods definitely are known to be aerosol generating, and for that reason, an N95 respirator needs to be used while you're doing these procedures. Next slide. So there are a lot of guidelines and tools, toolkits that are available, but as you'll find, a lot of the guidelines when you actually research back, as I've said before, they're about pandemic flu. However, they still are able to provide very, very good guidance for knowing how to use personal protective equipment and what to use in what circumstances. Next slide. Next one. How do we prevent and how do we use, actually this is from all the following information, or a lot of the following information will be from the Public Health Agency of Canada, and I've used the Canadian Pandemic Influenza Plan for the health sectors that was published in 2011. And these are prevention and control measures that have been recommended and well researched, because the thing about doing pandemic planning is that it has to be done ahead of time, because influenza was seen as the most likely culprit. In fact, I don't believe that anybody ever thought of the coronavirus as being such a huge threat as influenza in any fashion. And here we are with the coronavirus causing more problems. So all of the guidelines from all provinces and from the CDC and from anywhere that you might want to look at guidelines always recommend measures and break down measures into 3 levels of control: engineering controls, administrative controls, and then PPE. And literature shows that the most effective measures are always engineering and administrative controls. But in practice, most people focus on using PPE as their main source of transmission control. Engineering controls refer to measures that control human factors involved in transmission. Establishing good engineering controls forces us to review how work is completed in a particular area and makes use of room design, workflow, airflow, traffic patterns, and positioning of preventative supplies such as alcohol-based hand sanitizer, sinks, garbage cans, laundry bins, hands-free devices, physical barriers, and personal protective equipment to minimize the possibility of transmission. And it's the location and the design of where these things are positioned based on what people do in a particular area that is of utmost importance, rather than just simply thinking about the personal protective equipment that's actually available. How waiting rooms are designed as well, and where people work and what people do in specific areas to ensure proper workflow and less cross-contamination. Next slide. Administrative controls are the second line of defense to prevent transmissions. They make use of policies and procedures, such as procedures for triaging patients, point of care risk assessment, and transfers between areas or facilities, as well as workplace health policies for fitness to work. They also include policies regarding education on hand hygiene, environmental cleaning, routine practices, and additional precautions, and fit testing for N95s. Education is absolutely critical, because otherwise the personal protective equipment that's being used can actually cause transmissions. And if the focus is on personal protective equipment rather than on correct hand hygiene technique or environmental cleaning, then the personal protective equipment can become contaminated and also cause transmissions. So practices such as effective hand hygiene, environmental cleaning, and correct donning and doffing of personal protective equipment, they all sound very easy to perform, but they're actually done in a very inefficient manner for the most part. And correct education and ongoing education and reinforcement needs to happen. Next slide. So whenever possible, the recommendations are to use single rooms for patients with respiratory symptoms. Obviously, that's not always possible. So separation is very, very important. Assessing staff for symptoms and making sure that the person accompanying the patient is also assessed, and that the patient who has respiratory symptom is actually given priority for wearing something to cover their mouths, surgical mask, or even a cloth mask, so that droplets can quickly be caught and not be transmitted or spread through the air or through fomites. Also, telling the accompanying person to immediately leave the facility when they leave the particular office or space where they're staying, rather than walking around touching things and or visiting or talking to other people. The accompanying person with symptoms, whether they're a patient of yours or not, also needs to wear a mask and be asked to do proper hand hygiene and keep their distance from healthcare staff. Next slide. In the waiting room, ensuring that things such as signage, especially in multiple languages based on your patient population, needs to be present, and especially at the entrance where they'll be farther away from the reception staff. Instructions and proper equipment needs to be present as well at the entrance, so that upon entering your clinic, the patient or the accompanying person can make sure that they're not contaminating your entire area. There needs to be physical separation between infected sources and other clients, especially with susceptible hosts, patients who come in and have immunity issues. The garbage cans and other equipment that should be hands-free as much as possible as well, so that, again, there is less risk of cross-contamination. And waiting rooms need to be free of magazines and toys and pamphlets that people can take and touch and put back on the shelf. Something to keep in mind is that although all of the guidelines recommend that a mask be placed on a symptomatic person, an N95 is never given to a patient or a person accompanying a patient. And that's because an N95 actually needs to be properly fit tested and properly used using correct technique in order to work correctly and have a benefit when compared to a surgical mask. Next slide. So one of the most important parts of administrative controls is doing point of care risk assessments. And this can help make sure that personal protective equipment is being used with the higher transmission risk situations. And how are high-risk situations identified? Well, they're identified based on the following criteria. The first one being the source of the infectious agent. A source with a higher amount of respiratory secretions, we know with coronavirus, also can definitely transmit the organism a lot more. And I'll show you a bit more data about that. A person who frequently coughs or sneezes will definitely spread the organism more. And a person who has poor compliance with respiratory hygiene. So you ask them to wash their hands or not cough in their hands, to keep their mask on, but they're not complying. If aerosol generating procedures need to be used, these are more high-risk concerns, and should be definitely using higher precautions. if the person is not able to care for themselves or to do things for themselves. If they're immunocompromised, they have a higher level of viral shedding, most likely, as has been seen with other outbreaks and other respiratory organisms. And if you're unable to cohort them or there's not enough space. Next slide. So the environment also can cause a higher transmission risk. If people have to share the same bathroom, that bathroom can become an environment for transmissions to occur, especially when there's little housekeeping or cleaning being done in between patients or in between staff, the healthcare workers. If there's a prolonged or frequent contact that has to happen in your clinic, and if there's not enough separation or ventilation in the room. Next slide. And the last criteria is how susceptible is the host, being the patient or the healthcare worker. I crossed off some of the things that discussed influenza virus directly on these slides, but most of these transmission risks are the same for any respiratory infection. So is the healthcare worker doing proper hand hygiene or not doing hand hygiene adequately? Are they using PPE appropriately? Are they donning and doffing PPE appropriately? Or are they spreading the organism via their PPE? Are they immunocompromised? Next slide. Another administrative control has to happen during transfers. Is there adequate communication that's being done with the people doing the transporting, such as EHS or other modes of transport? And is the receiving department or facility being told of the case coming in? Also, the patient with the symptoms needs to perform proper hand hygiene, wear a mask, and practice respiratory hygiene during transport. Next slide. So whatever personal protective equipment is used, the number one error that seems to happen is not doing hand hygiene prior to donning or touching the outer surface of the PPE. Some will even prepare their PPE by throwing it on a contaminated surface and then putting it on. So that's one of the number one ways in which transmissions can easily occur via PPE. If gloves are touched with dirty hands, then the organism is then on the outside of the gloves and the gloves no longer have a purpose. Next slide. So one of the big questions that are asked frequently is, should you wear a mask or should you wear a respirator? And although there is no evidence of transmission of COVID-19 having occurred via airborne means, the guidelines clearly define when to select a mask versus a respirator. According to the guidelines for pandemic influenza for Canada, says that healthcare workers should wear a mask and face or eye protection when the healthcare worker will be working within 2 meters of a symptomatic patient. They should wear a respirator and eye protection or facial protection when the healthcare worker will be working within 2 meters of an influenza patient or a symptomatic patient, and the patient is coughing forcefully, or the patient is unable or unwilling to comply with respiratory hygiene, or the aerosol generating medical procedure is being used. So something that's important to note about masks versus respirators is that there are no requirements related to the filtration abilities of simple surgical masks or dust masks. We call them simple surgical masks or surgical masks because they were actually created, those particular masks were created for surgeries so that droplets would not be expelled from the mouths of healthcare workers while they're doing surgery. So they're actually there to just catch large droplets exiting the mouth while speaking or while breathing. And they're quite effective in doing that. The level of filtration is not something that's regulated. However, some studies comparing N95s and surgical masks have found N95s with large air leaks around the face, or even with any air leaks around the face from not being fit tested properly, or the fit actually checked right after donning. Those air leaks actually make it so that a simple face mask is equally effective in many circumstances to an N95 with air leaks. That's because an N95 with air leaks actually has so much resistance from the high level of filtration from the respirator that the particles and the air will actually go in through the air leak rather than through the respirator. And such a large quantity of the air will pass through that air leak that in fact the filtration is negated. A surgical mask has many air leaks, but because there's very little resistance from the actual fibers of the surgical mask, a lot of the air will actually still pass through the surgical mask rather than through the air leak. However, when donned properly, an N95 is definitely a high efficiency particulate filter that is very well tested so that it filters 95%, it's guaranteed to filter 95% of particles of 0.3 microns. That selection of 0.3 microns is very important because it's actually the hardest particle size to filter. Anything above that is just caught in the fibers because it's large enough to be caught. Anything smaller than that, because the N95s are actually electrically charged on purpose, they have an electrostatic charge inside the HEPA filter, that electrical charge will actually capture tiny droplets or tiny nuclei. But the 0.3 micron seems to be the toughest one to actually filter. And so therefore, that's why all the testing is done on that size of particle. Because of the high efficiency material of an N95, if an N95 is to work correctly, it can't be cracked, it can't be bent, it can't be sanitized in any fashion unless it's been proven to actually work still after that mode of sanitization. Some people have tried to put things like alcohol spray on their N95 thinking that it'll just kill the germs on it. But what it does is it also damages the electrostatic charge within the fibers. Some others have tried to use heat and other modes to try to sanitize the N95. But like I said, unless testing is done to prove that the N95 efficiency has not been damaged, I would definitely not recommend doing that. So I'm just going to mention again that it is never recommended to give an N95 to a patient or visitor. And as I've mentioned, you're not doing them any favors by giving them an N95 because it will not be fit tested properly. In fact, even just a small amount of stubble on a face will break the seal enough so that the N95 will not protect the person wearing it correctly. So the reason why patients and visitors who are symptomatic need to be prioritized for wearing masks is that most of the droplets that exit the mouth are actually quite large at first and then desiccate as they dry up in the air and float away. So it is a lot easier to prevent contaminating the environment by putting a surgical mask or something to cover the mouth of the person that's coughing or sneezing, rather than have to deal with the particles that are floating around the air or dropping onto surfaces afterwards. It's also recommended not to allow patients to cough or sneeze into their hands, because afterwards, then they transfer the organism with their hands. Hence the use of the surgical mask on patients who are symptomatic. And requiring them to actually do proper hand hygiene as well. One of the big concerns that happens when patients actually wear surgical masks or any type of cover on their face is that when they cough or sneeze or speak, they touch their mask and respirator. And especially if they're about to sneeze, the automatic reflex is to put your hands up and to remove whatever's covering your face so that you can cover your mouth with your hands. So patients have to be instructed not to do that. Next slide. So what do we know about the uses and limitations of N95s from 3M, the company that actually produces them and tests them? We know that they are capable of filtering out particles such as Mycobacterium tuberculosis that are able to survive as tiny nuclei floating through the air, completely desiccated and completely dry, but are able to survive in the air currents for long periods of time. We also know that storage and shelf life it can be made a lot shorter by keeping the respirator at extremes of temperature or in high humidity. So we know that humidity, moisture, light, UV, and other things can damage the respirator. Also, just physical damage can damage the fibers. Next slide. So they clearly state that you cannot alter, abuse, or misuse the respirator, therefore cannot sanitize it. Number 4 says, do not use with beards or other facial hair or other conditions that prevent a good seal from the face. And that's, again, because if there is not a perfect seal, a lot of air will pass through there. Number 6 says the respirator is designed for occupational and professional use by adults who are properly trained. Again, so that a good seal will actually be made, and also so that the PPE will be put on and taken off correctly without contaminating the environment or contaminating the user. Individuals that have a compromised respiratory system, such as asthma or emphysema, etc., shouldn't be using it. And that's another issue with people who have acute respiratory symptoms. If they have acute respiratory symptoms, they're going to have a very difficult time breathing through the respirator anyhow, without creating an air leak. Next slide. So what do we know about the behavior of droplets and droplet nuclei? We know that the distance traveled by particles is largely due to its size. The larger the droplets, the more quickly they drop. In fact, usually droplet nuclei are considered the ones that stay in the air for an extended period of time, are seen to be, or usually judged to be approximately 5 micrometers or less in size. So we know that here, according to this slide right here, from Protecting the Faces of Healthcare Workers, this was a big guideline that was actually developed in British Columbia to plan for the next pandemic. And in there, they actually show that the particles that are less than 10 micrometers can stay for several hours suspended in the air. However, it says that this equation does not consider the effect of droplet evaporation. Some organisms live quite well as the droplet evaporates, but other organisms, such as usually respiratory viruses, such as influenza and coronavirus, usually do not survive well when they're suspended and evaporate in the air. In fact, dry air inactivates a lot of respiratory viruses. Next slide. So what droplet size do humans produce when talking, coughing, and sneezing? Again, this is from the faces, protecting the faces of healthcare workers document that has many, many, many studies included in the document and discussed at length. As you can see from this study, only a small proportion of droplets may remain suspended in the air for extended periods of time. So those top two lines right there are the ones that are the right diameter for being suspended in the air. And only 1.2% can remain suspended after a sneeze, and 0.8 from coughs. And when speaking loudly, 0.7. An open mouth cough seems to have the largest amount of small particles created. However, as mentioned in the last slide, the coronavirus usually is not very viable on desiccated droplet nuclei. So although it's still possible technically for these types of droplets to be created, the virus also has to remain alive in that tiny droplet nuclei for it to be a transmission risk. And as we know, coronavirus is not usually viable on desiccated droplet nuclei. However, risk is associated with the concentration of droplets in the air. So based on research, it's also critical to minimize the total concentration and to consider areas of high concentration as more high risk. Therefore, all provincial guidelines focus on the following areas. Again, give symptomatic patients something to cover their mouths and nose, and teach them about respiratory etiquette and hand hygiene. Doing lots and lots of environmental cleaning, minimize fomites around patients that would need to be cleaned after they've left, and consider perhaps using things like a HEPA filter in the room, especially in small rooms with very little circulation of the air and filtration of the air. Next slide. So what do we know of the survival of the coronavirus on surfaces? Here, this is the time that infectious aerosols are, remain alive. And so as we can see, it's really highly associated with the titers that are shed. As the person is shedding more virus and coughing more, the more quantities of virus, especially more quantities of virus in mucus, so that it can remain alive, then those viruses are theoretically able to remain alive for a very long period of time. So this table shows the viability and infectivity of the coronavirus are highly related to the quantity of virus that's produced. But this study was done with no air exchanges and in dry conditions. Next slide. So according to the guidelines, masks or respirators need to be removed very, very carefully in order to not contaminate the user. In fact, we know very well from the SARS pandemic or outbreak that some healthcare workers actually contaminated themselves, what we call self-inoculated, when they were removing their N95s. If they are rubbing their faces with their N95 as they're lifting it off their face upwards. So N95s or masks also need to be removed using only the straps and then put directly in the garbage, because there is no safe way to reapply used N95 or a used mask. It would be impossible to make sure that the inside portion that actually touches the face is now not going to contaminate the user. So the external surface of the N95 or respirator mask cannot be touched. The respirator and mask cannot dangle around the neck. It can't dangle from one ear. It needs to be changed as well when it's wet or soiled. Otherwise, creates a lot of resistance when the person's trying to breathe. And again, they'll be prone to lifting it up to create an air leak. Hand hygiene has to be performed absolutely before touching anything that will be put on the face, and also hand hygiene after removing it, before and after removing it. However, the guidelines for pandemics for Canada clearly state that the mask or respirator may be worn for sequential care of influenza patients. Next slide. Eye protection or face shield should be worn whenever a mask or respirator is worn. The difficulty with eye protection is that on one hand, it can be cleaned or reprocessed if according to what the manufacturer states, but there are certain pieces of equipment with foam, for example, some face shields that have a foam a piece of foam on the forehead, the foam would not be able to be reprocessed. So if a user wants to, or a clinic wants to have PPE that's reprocessable, the equipment that's purchased needs to be properly reprocessable. Also, it should not interfere with the mask or the respirator. It's critical that the goggles or glasses that are being used have not only a fairly good seal around the eyes to protect from droplets, but also that they don't actually push down on the N95 and cause an air leak with it. Again, at the very bottom, you'll see that eye protection or face shields may be worn for sequential care of influenza patients. By the way, my favorite is probably a face shield. I find that there's definitely less cases of having them fogging up, plus less interference with the respirator or mask, and also they help catch the droplets as well. Next slide. According to the guidelines, gloves should be worn when coming within 2 meters of a patient with who's symptomatic with ILI. That's mostly so that the person making the person aware that any of the objects that are located within that 2-meter radius are also considered to be contaminated if the person is symptomatic and coughing or sneezing, etc., even talking. So when caring for a number of influenza patients, the gloves must always be changed. They cannot be worn from person to person, and they can never be sanitized. I've seen in many clinics people who believe that if they dip their gloves in alcohol, etc., that they'll be able to reuse them or use alcohol hand sanitizer on their gloves or wash them with soap and water. But the fact is that the material of the glove will get damaged with the alcohol and the water, etc., and make them porous or create micro tears inside the glove material. So in fact, it's probably a lot smarter to use simply a different type, instead of using nitrile gloves, using vinyl gloves for any intact skin. However, gloves must always be worn for contact and prioritized for contact with mucous membranes and blood and body fluids. In order to decrease the amount of transmissibility from hands, nails must always be kept short, and no jewelry should be worn on the fingers and wrists so that you can properly do hand hygiene. It's hard enough to actually do hand hygiene correctly, but if you have the interference of having objects on your hands or long nails, and especially glued on nails where the glue can also hide a lot of microorganisms, then it makes hand hygiene very, very difficult or almost impossible to do correctly. Making sure that hand hygiene is done properly before and after contact with patients, and now done very, very diligently with a lot of scrubbing. When alcohol hand sanitizer is being used, the hands have to actually have enough alcohol on them to remain wet for the appropriate kill time. Appropriate kill time for alcohol is approximately the alcohol must go through all the crevices, cracks, and even the nails of the hand. Also, when doing environmental cleaning, all the surfaces touched by the patient and healthcare worker must be wiped with a disinfectant wipe. Something that's also not done correctly very often is not leaving the chemical for the appropriate kill time. Something such as bleach has a kill time of approximately 1 minute, but something like an ammonia product or a quat, such as cabbie wipes, will have a kill time of 10 minutes. That means the surface needs to actually remain wet for 10 minutes before you can consider that surface to have been disinfected. Activated hydrogen peroxide solution is also between 1 and 3 minutes. However, the activated hydrogen peroxide solution will not leave a residue that's toxic on the surface like a quat or a quaternium ammonium product does, such as cabbie wipes. Something to keep in mind when you're using disinfectants, though, is to make sure that you're not using ammonia products and bleaches in on the same surfaces at the same time, and mixing the two chemicals, as they can release chloride gas that's has no odor, however, is very poisonous. So ensuring that gloves are removed using the proper technique is also very important. If gloves are being used, then removing them, putting them on with clean hands, touching them only with clean hands, not removing them with any snapping, making sure that they roll off the hand and then get thrown in the garbage. And right after, always clean your hands to make sure that if there were any micro tears or anything like that, and organisms got through the glove, because they're not perfect, that the hands are sanitized. Next slide. So according to the guidelines as well, gowns should be worn with contact with clothing or skin or the immediate environment around 2 meters of any patient who is symptomatic. And gowns must be changed between all patients. You also need to wear a splash guard gown or a plastic cover of some sort in case there's splash with blood and body fluids. However, gowns can be reusable. Anything that's made of fabric can be used for contact with something dry. However, when you do remove a gown, whether it's disposable or reusable gown, it needs to be placed in the laundry bin or garbage can within that room so that you don't contaminate the rest of the environment as you're walking through the hallways and entire area. of your clinic and then spreading viruses everywhere. Also, when gowns are removed, they need to be removed using proper technique and being rolled forward, so keeping all the contaminated elements on the inside as you're rolling it away from you. Next slide. I've already mentioned a lot about environmental hygiene, but environmental hygiene is so important. In order to do proper environmental hygiene, clutter needs to be removed. If you're working in a cluttered environment where paper is on all the shelves and the counters and the areas where your staff are touching various different things on a regular basis, that clutter is going to make it very difficult for anyone doing any cleaning to actually disinfect the area properly. Making sure that you're using proper hospital grade disinfectant is important as well. Viruses are actually a lot easier to kill than a lot of organisms. However, still need to make sure that it has the proper concentration. For example, the best type of alcohol hand sanitizer is 70% or more. However, in stores, very often what's sold is a 60% concentration. Doing meticulous daily cleaning and cleaning between patients is highly important. Also making sure that any equipment that's being used with the patient is being disinfected, such as a stethoscope, sphygmomanometer, or blood pressure cuff, etc. And thinking that, as for example, the cuff is being wrapped around the person's arm, and then the same person who wrapped the cuff will then press the button of the automatic blood pressure machine. That button has also is also potentially a fomite for the next transmission. So making sure that equipment that's attached to the wall is also being wiped down. Next slide. So the CDC also has some recommendations for disinfection and cleaning, and they tell you exactly what to use and even tell you how to mix it properly. At the bottom of the page, you'll see it says prepare bleach solution mixing, 5 tablespoons, 1/3 cup per gallon, etc. If surfaces are dirty, they should be cleaned first, though, using a detergent and soap and water, because a lot of these disinfectants actually do not clean first. So when you're using a cavi wipe, you can think of the first wipe as being the cleaning wipe and the second wipe as being the disinfectant that has to be left wet. Also making sure that wipes are only being used once. If the same wipe is being dipped in the bucket after wiping a surface, then the bucket of disinfectant, if the wrong concentration is being used, or if it has a high level of organisms inside the cleaning fluid, then that bucket can get contaminated and therefore spread the virus around. Same thing with cleaning cloths. Using one dip technique and then washing the cloth, or using disposable cloths to wipe surfaces is a lot better. If you're cleaning touch screens on your computers, make sure that you're not using bleach or ammonium products. You need to use, and in fact, that's what the CDC recommends, is to use a 70% alcohol solution on your screen. Otherwise, it will completely damage your screen very quickly. Same thing on blood pressure machines, etc. The screens, they're easy to damage. And on the next slide, that's simply something coming from, again, the CDC, showing how to create a mild solution for hand hygiene in case you do not have soap, or you prefer to disinfect your hands and you don't have any alcohol hand sanitizer, or making a solution, a cleaning solution for your surfaces. Next slide. And the next 2 slides are just my references. Are there any questions?
Thank you very much, Valerie. It's Scott here again. So just a reminder to anyone who has questions, if you could please type them out in the questions pane or put up your hand, and I'll try to scroll through and unmute you so you can ask questions. Please ask you for your patience as I scroll through these to make sure we collect all of your questions. One moment. It looks like we do have one or two questions already. I'm just figuring out how to open this screen. Okay, so one moment. I don't believe you already answered this. One question here is, what about low flow oxygen therapy? So less than 16 liters per min using a non-rebreather mask.
So what's the question exactly about the low oxygen?
It says, what therapy? I believe it says, what does the evidence say about N95 use for this?
Oh, using low flow oxygen? No, as far as I know, there's absolutely no evidence that it's necessary. That's definitely not seen as an aerosolizing procedure.
Okay, the questions are flowing in here, so just a moment. Can you repeat the kill time for alcohol?
Yeah, for alcohol, it's 15 seconds. For alcohol hand sanitizer, 15 seconds, where it has to actually remain wet.
Okay. Now, for any of you who've put your hand up for a moment, just bear with me. I'm going through the question pane first, and then I'll get to hands that have been put up. Next, what would you advise about a clinic room that has curtains? Would these need to be changed between patients or removed?
No, as long as well, it depends, I suppose, on how much the curtains are being touched. If it's a room where there's a lot of touching, or it's within 2 meters of where the patient is, the patient's face, then at that point, it could be seen as a lot more of a culprit for transmission or a fomite. But so it really depends on what's going on and where the organization of the room. Is there any more specifics about that room?
I'll wait to see if a follow-up comes. I'll look for that. That was a written question, but for now, no, that was it. So in the meantime, I'm going to go to one more question in the pane here. That's the questions that have been typed out, and then I'll take some questions via hands that have been put up. So the next question is, any special considerations for home visits in the community?
Oh yeah, home visits are definitely more of a concern, because of course, when doing a home visit, the person that's going into that home has to make sure that, well, they're going to definitely come in contact with the patient's environment, and so therefore need to wear all of the PPE, including a gown and gloves and facial protection.
Okay, I'll take a question.
And change those in between each patient, because there's no way that the person can then go in their car wearing their facial protection and go to the next area. I don't see how the facial protection can even be reused between people in that setting.
Thank you, Valerie. I'm going to call out your name if you've put up your hand and unmute you, so you can try via your microphone to ask your question. If that doesn't work, if we have silence there, then perhaps you could try typing it out. But let's add some texture here. I'm calling now on Destany Bucco. You've put up your hand. You've been unmuted if you want to go ahead.
Hi, can you hear me?
Yes, we can.
Yes, I can.
Perfect, thank you so much. So my question is in terms of using a BVM. So our part of the center is consumption and treatment services. So we do overdose response, and currently any staff who respond to an overdose needing a BVM, they use an R95. In terms of the surfaces being able to hold the virus for hours or even days, if we use a BVM in that space, what are your recommendations for sanitizing the space or potential closure of the space following that? Was I clear enough?
Actually, can you explain to me what a VVM is? I've never heard of that.
Sorry, a BVM.
BVM, what is this?
The breather valve mask.
Ah, breather valve mask. Okay, there we go.
Sorry.
So what is your usual protocol for BVMs?
So right now, because of the virus, they've implemented donning and doffing properly with the R95. And if they are in need of a BVM, that is like with the overdose, if they need assisted breathing, they use that while we administer Narcan and so on with the overdose response. But just in terms of aerosolization of the virus in the room and our surfaces, the room is quite small. So if we do use a BVM on a client, what should we do moving forward in terms of the space?
In terms of the space and what to do with the space once you leave? Is that the question?
More so like if, let's say this client is asymptomatic, but has the virus and the virus has now been aerosolized in the room, will the virus then stick on surfaces, and do we need to close the room down for a bit and not let more clients in afterwards, or certain cleaning protocols for the space?
Yeah, I mean, and you're totally right. After an aerosolizing procedure, if it's considered to be an aerosolizing procedure that you're actually using in that room, normally it takes approximately 1 hour for the air to clear out of a room after airborne precautions is being used.
Okay, thank you so much.
That's what we use in a hospital setting, but that's with the cycling of air that's found in a hospital setting. And I know nothing about the rooms that you're using and how quickly the air is cycling through. If you're not getting a whole lot of cycling, like I said, like in a clinic setting where really I have no idea how quickly the air is being cycled through, then using something like a HEPA filter would be very, very useful. Obviously, it also needs to be cleaned down afterwards. Anything that's been touched, yeah, absolutely. The surfaces within a 2 meter radius, at least around that patient.
Valerie, you cut out.
Okay, great. Thank you so much.
You cut out for a quick second at the end. If you just want to repeat quickly what you said, the last 10, 15 seconds there. 10 seconds, maybe.
Oh, I see. I was saying that, in fact, I can't remember where I left off. So it was, I was saying that in the hospital setting where I already know how quickly the air is cycling through a room and how long it takes for the air to be cycled through, then I know that it's going to take me less than an hour. So usually the rule of thumb is 1 hour for the air to have cycled properly so that the air is now considered clean. That's after using aerosolizing procedures in that room or after having a patient on airborne precautions for any reason. So during that time, an N95 has to even be used in the room if, for example, you go in there to clean, so that the air of the room is considered to be contaminated during that period of time. And then, of course, the room itself has to be cleaned. So I was saying that in a clinic setting or in a place where there might not be as good of air cycling, you can actually install pretty easily some HEPA filters in the room, like 1 HEPA filter in each room to make sure that the air is actually being cycled and filtered properly.
Okay, great. Thank you. I just want to make sure that it was clear. So I'll take a next question. I'm going to unmute Laura Bantock. Go ahead, Laura. I'm trying to unmute. There we go. Go ahead. You should be able to.
Hi, can you hear me? Thank you very much for a great presentation. My husband is a family doctor, and he was one of the first to sort of go public in British Columbia to sort of try and influence behavior that we were seeing, which was quite worrying. So he was tested positive, but from the onset of symptoms, I'm an RN, and I dredged up what I knew about barrier nursing, and I set about barrier nursing him within 1,000 square feet in our condo.
Yeah.
And we're at day 14 today, and I have no symptoms. So I can only think that what I did worked.
Absolutely.
So I have been asked by multiple people, including the Division of Family Practice and actually BCACHC, to kind of scratch out what I did with very little supplies, literally using what I had here to do this, so that it could possibly become a patient handout for people trying to do this.
Yeah.
So anyway, I've scratched it out, and my question was really, would you review it very
Sure.
quickly and provide some feedback to
Sure.
me? If you do that, maybe you could, or Scott could send me your email, and I could just send it to you.
Oh, sure. Yeah, no problem.
Absolutely.
My second question is just as a follow through from that, about cleaning the isolation area, which in my case is 1 bedroom and 1 bathroom. I was thinking to shut it down, bleach. I don't know if you have any experience or any advice, or actually any other protocols that you might have that have already been done like this for patient use.
Okay, so you're asking about what technique to use to clean, or what concentration of product, or what product, or?
No, I'm just really wondering, obviously in the bedroom there's a lot of soft surfaces, and
Oh,
I've
I see.
kept
Okay. Yeah.
I've kept his linen in, or
Okay.
he has kept his linens in a garbage bag to be washed after
Yeah.
the isolation period. I tried to do it just like a hospital would do it.
Yeah.
But I'm thinking about me going in and sanitizing that bathroom and that bedroom.
Yeah. So the thing about the carpet, etc., is that what they recommend for on the CDC website for things like upholstery and carpet is to just use, if you really did want to sanitize it really well, to do some cleaning, like carpet cleaning. And upholstery cleaning. For things like bed linens and clothing, you just wash them as you normally would with your laundry, and the normal process of laundry washing will definitely deactivate the virus. Absolutely. The part that you have to be careful about is when you're putting the laundry in the machine. That you don't contaminate yourself, obviously, and it's easy to do when you're trying to move lumps of laundry. So just being very, very careful about that. When it's coming out of the washing machine, it's no longer a problem anyway. So it's that's not an issue. And when it comes to cleaning the inside of your house, the thing you have to be concerned about is what products you're allowed to actually use on the surfaces that you have, because things like using marble in your house, if you have marble counters or marble floors, there are certain products that will definitely damage it, such as bleach. So a one-time bleaching might not actually do a whole lot of damage, but definitely if you were going to be doing that on a regular basis, you'd probably really damage your marble. So you have to be careful about using appropriate products that actually are okay to use on your surfaces. That's the biggest problem that you'll encounter there.
What do you think of the idea of actually just closing that room for a few days?
Yeah, well, that's still, I mean, yes, you're right that over time the viral load will decrease. However, you know what? I think that it's still, considering the fact that, the person can still have coughed quite a bit of mucus that is now dried in surfaces, etc. Those surfaces we know like can stay infected for quite a while. I think it's a lot smarter to disinfect it. A lot smarter. Yeah.
Okay.
Great.
Yes.
Scott here jumping in. Laura, if I could, just because I do want to make sure that we focus as much of the time as possible really
Yeah.
on the community health center setting, just for folks
Yeah.
asking questions. I'll make sure to connect you with Valerie offline. And I know what you're developing there would have immense value to folks,
Yeah.
especially if it's vetted by Valerie, and we could share that certainly within British Columbia, but more broadly. So I'll make sure to do that. Is that okay?
Perfect.
Thank
Thanks
you.
so much, Laura.
Thank you both. So I'm going to go to read some more questions here because we have quite a few that have been typed out. So the next one is, do we know yet if people become immune after they recover from COVID-19 infection?
Okay, well, what we know really so far is that there are a lot of viral strains for coronavirus. Like I said about the influenza virus and why it causes us a lot of trouble is because it mutates a lot. It's the same with coronavirus. It seems to mutate quite a bit. And in fact, when I was reading what they were doing in Iceland right now, they're actually showing that they can identify what strain people have caught in Iceland while they're doing their testing. So they actually, there are strains from North America, even different regions of North America, from areas in Europe and in various different countries. There are quite a few different substrains that are actually floating around. And I was suspicious of that, in fact, when, you know, you're seeing that the, that there seems to be more deaths in certain countries than in others. Could be related to a lot of factors, including resources, including, you know, all types of things, perhaps even distancing precautions that are not being abided by properly in certain countries because they're not culturally very acceptable, etc. Who knows? But the fact is that there are a lot of substrains. So yes, people can become immune. I am absolutely sure of that because I know that people are now testing positive for having antibodies for the coronavirus. And that's all very, very good news because you have a decreased susceptibility. However, you could still get reinfected by a similar virus. Now, would you get reinfected and have a severe illness from it? That's a question that still, so far as I know, has not been answered. And to me, it sounds like it's not very reasonable to think that if you've been infected with one strain, then a sister strain or a very similar strain would cause you a severe illness afterwards. I think that that's probably not reasonable based on everything that I know about viral infections.
Great. Thank you, Valerie. Next question here is, some health authorities are now recommending that healthcare workers use PPE, mask, eye protection gown, and gloves for all direct patient contact in order to mitigate COVID-19 transmission risk. What's your response to this, and how do you see it applying to the community health center context?
I think that the biggest problem with that is if you're not using your precious PPE for people who are higher risk and looking at transmissibility and that sort of thing, what ends up happening very often is that you'll run out of PPE, or PPE will not be used properly or correctly, removed and taken put on, taken off. People often see their PPE as protecting themselves from catching the organism, when in fact PPE is there to actually prevent transmissions from person to person. And that's yourself included in that transmission risk. But it's really, that's the PPE is often misused so that it's only protecting the person wearing it. So therefore, in their mind, they think, you know what, I'll just put on my one set of PPE and I'll go person to person. They're all, you know what, they're asymptomatic. So I'm just going to move from this person to that person to that person to that person. Well, the problem is that when you're wearing PPE such as, you know, gloves, you can't wash your hands properly. You can't disinfect your gloves. And when you're wearing things like a gown, the gown actually dangles and has, you know, a lot of parts that actually make it so that it has more contact with surfaces than your outfit normally does. So sometimes it can cause more transmissions just by wearing the PPE inappropriately. Now, if you are going to wear PPE, you have an endless supply, and you want to go take care of people always wearing PPE, always doing hand hygiene, taking things off and putting things on properly in between, and you want to do that, then you know what? I always say, all right, why not do more than what's recommended? Is there value in it? Well, there's value in your mental peace, perhaps, about how many transmissions you might be causing or the risk for yourself. But is there any evidence that that actually will prevent transmissions? As far as I know, no, there isn't. And even just walking into a person's room with no gown and gloves and remaining outside of that 2-meter parameter, there's no evidence, just like Laura was actually talking about, keeping proper distance between people and keeping proper barriers up, etc., and being very careful. You can live even in the same house for an extended period of time and not cause transmissions. If this virus was really actually airborne and floating through the house, etc., we would have seen that with all the cases that have occurred. Now, like I said, there are many viral strains, so it's possible that things will come to light in the future that we don't know anything about right now. But anyway, that's my response.
No, great. That was very thorough. Thank you, Valerie. Just to let everyone know, because a few people have asked, we will make the presentation available, so you can reference Valerie's slides afterwards. So we'll follow up with information about accessing the slides. I know there was a lot of really detailed information that you want to share, reference again, and share with colleagues. Next question: any recommendations regarding wearing masks, even for asymptomatic patients in case of pre-symptomatic viral shedding?
I, again, love the idea as long as the PPE is being used correctly. And that's the most important part. Going person to person who are asymptomatic wearing a mask. And remember, eye protection must always go along with the mask. So if you're going to take the precaution of protecting the mucous membranes of your nose and your mouth, you have to make sure that if you see that there is a risk and therefore you want to do that, then you have to protect the mucous membranes in your eyes as well, because we do know that there is a risk there as well. So when you're using facial protection, so I'll just call facial protection the mask with the either face shield or goggles, if you're going to be wearing it person to person, then you have to be absolutely diligent that you are not touching those surfaces at any time. And if you're going to be using something such as an N95, making sure that it's donned properly so that it has a proper facial seal, so that it actually serves its purpose rather than just simply wasting resources. Also, I've seen people use 2 masks on their faces thinking, well, if one's good, then 2 must be better. When in fact, and believe me, I'm not ridiculing people who are trying to protect themselves. This is scary. So I can understand why people make these types of decisions. However, there is absolutely no value that's ever been seen in that. In fact, when you have 2 masks on, very often they become skewed, they rub against each other, and you're way more likely to touch them. And the big risk is really touching your facial protection. Touching it is the biggest risk to you, and touching your face.
Great, thank you, Valerie. Next question, and I assume the question is not related exclusively to comfort, but also in terms of hygiene and sanitation. Just hands get very dry. What are the hand lotion recommendations?
Oh, I see. Yeah, I know. I've searched so much for proper hand lotion recommendations, but to tell you the truth, I've never encountered any proper recommendations for hand lotions. So whatever really kind of works for you, the thing is that you have to realize that if you're wearing very like petroleum-based sort of or oil-based lotions on your hands and then using alcohol hand sanitizer, I always questioned just how good the penetration was of the alcohol through that oil-based lotion. And again, I've never been able to find an answer to that question, and it's always caused me a lot of trouble whenever anybody asked me.
I'm going to call the CDC hotline now and see if they.
Yeah.
Next question. Where can I find the guidelines for wearing N95 for patient coughing forcefully? not complying with respiratory hygiene.
Oh, I see. Yeah, coughing forcefully, that is on the Canadian guidelines. So let me see. Can you move my slide one back?
One back, one moment. How do I go back here? Back. One sec.
So the one that you see right here, okay, so on this first slide, oh, it's too bad it's all bolded. I didn't realize I did that. So the PHAC Annex F, prevention and control during a pandemic, blah, 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 all that right there. The number 2, prevention and control of influenza during pandemic for all healthcare settings. And then I have the link right there.
And presumably if someone just pops that into Google.
Yeah, it's a PDF. It'll work. I know because I've been copying stuff from it directly so that I didn't alter any of the information that was written directly on there. And remember, this was done based on everything that they could think of. And the reason why it says, you might think to yourself, well, it says influenza. Yeah, but the fact is, in the guidelines, they talk about any novel organism, no matter what that organism's behavior is like. So yes, they refer to it always as influenza because that was always the one that everybody expected to cause a pandemic. But the fact is, even if it had been influenza, we still would have had to study it exactly like a novel virus. So that shouldn't really matter in terms of following those recommendations. And on the next page, you'll see an excellent article that I really recommend, and it is the one. So if you, yeah, right there, the Yassi Bryce Jansen Copies, the second one, that's right there, right under 3M. It says protecting the faces of healthcare workers, knowledge gaps, and research priorities for effective protection against occupationally acquired respiratory infectious diseases. That document is very thorough and very well written, and you'll find it very enlightening.
Great, that's helpful. And just to make this easier and more accessible for our community health center members, we've created two COVID-19 sections on our website, the Canadian Association website, one for the public and one for community health centers. I will make sure to add those two resources that you just referenced directly to our section for community health centers. So they're reliable resources.
And if you cannot locate that one, I have a copy, so I can send it to you.
Wonderful, thank you. A few more questions here, and folks are hanging on, so I know there's interest in hearing more and sharing more. Just a clarification question. So you mentioned using Cavi or Virox wipes to disinfect surfaces, and just want to confirm these are okay for equipment and screens, but bleach-based cleaners should not be used as they can cause damage. That's correct? That's what you...
Yeah, that's generally what's recommended. Now you have to look at what your the manufacturer of your equipment actually says about cleaning. That's very important because it's impossible for me to know exactly what your equipment is made of, and you know what the so you have to actually read the individual manufacturer's recommendations. But as a rule of thumb, in the hospital, we use alcohol for screens. We use very often Virox or Cavi wipes for delicate equipment, and we use, or Virox or any other accelerated hydrogen peroxide solution, and then we use bleach for things like floors and hard surfaces. You have to be careful, of course, even with metals, because bleach will also break metals down. So Virox can be a lot better for that. All of these products actually do a great job at killing viruses. Now, the problem with it is really related to a few questions that you have to ask yourself. First of all, how much kill time do you want to have to give it? Like if you want to go for a short kill time, then you should pick something like either Virox or bleach and not an ammonium product. Another thing that you have to think of is what fumes are you able to tolerate? If you cannot tolerate fumes, then you should use an accelerated hydrogen peroxide solution instead of bleach. And another question that you have to ask yourself is, how tolerant am I of residue, because ammonium products will leave a toxic residue on surfaces that you shouldn't really touch that surface and then touch your food. That residue just stays on there, and in fact even accumulates as you use the product more and more. So ammonium products have those shortcomings, and but they're usually a lot cheaper, and you know, they might be easier to locate and find, and when you don't have resources, then sometimes you have to go with what you have.
Great, thank you, Valerie. I know we've gone over time. I have 2 more questions that have been queued up here, if we're okay to go through those and then wrap up.
Yeah.
And thank you all for holding on, and thank you, Valerie, for your extra time here. Really appreciate it. The next one is regarding home visits. Is PPE required for all home visits, or those where the patient or family is symptomatic?
So as far as I know, sorry, now I'm clearing my throat, 2 seconds. As far as I know, there is no recommendation for wearing PPE for asymptomatic patients, whether it's a home visit or not a home visit. But that's as far as I know. I haven't really researched it because that wasn't really the focus of my presentation. It was mostly clinics. However, you know, if a proper screening has to be done prior to arrival, and that's the #1 thing that I want to recommend. Making sure that when you do arrive, that person is not supposed to has not only had no symptoms, but has had no contact with anyone who's had symptoms, and making sure that you're doing that screening prior to entering the home. Also, you know, you will need, as you're doing home care, you will need certain pieces of PPE regardless, because you have contact with blood and body fluids. And if you're doing things like mobilizing the patient and they have respiratory, chronic respiratory conditions such as COPD, then they're very likely to be coughing on you. And so wearing facial protection is also required according to routine practices.
Great, thank you. And a variation of that, I suppose, and more just general information. And I know there's a lot of this circulating via social media and elsewhere. The really question around individuals and communities making cloth masks.
Yes,
A
yes,
lot
I
of
saw
that's
that.
happening. Would you say that's worthwhile? This is a question being asked here. Worthwhile for asymptomatic people in the community?
Well, I would say that for asymptomatic people, people do not need to wear masks at all. If they're doing it to prevent contaminating their environments, I don't see that there's actually a need for wearing a mask, because the problem is that, first of all, we know that with this virus, you're way more likely to contaminate your environment when you have a higher viral load when you're symptomatic. Also, when you're asymptomatic and you're just not naturally speaking, etc., you're not really contaminating your environment a whole lot. It's usually through coughing and sneezing that we're doing more contamination of our environment. And let's just say that you are asymptomatic, but you do have the virus, then that person is much more likely as well to be touching their faces all the time. For the community who doesn't know how to use facial protection properly, facial protection can clearly become a good fomite for self-inoculation. And so when the person is actually trying to protect themselves by using facial protection, but they are not really clear on how to use it properly, they're reusing the same dirty mask, etc., on a regular basis, they're way more likely to cause harm to themselves than actually to do any sort of protecting of themselves. So that's why in Canada, there is a strong recommendation against wearing facial protection for asymptomatic people. Now, wearing cloth masks, that was the other question. And I know I've been reading a little bit about that and everything. Now, the only recommendation I can make is that if you have nothing to cover the mouths of your patients who are coming into the clinic, I would save like N95s, especially N95s, but surgical masks for healthcare workers if you're running out of them, and give fabric, handmade masks, especially made of cotton. From what I've heard, they seem to capture droplets from the studies that I read. How good are those studies? I cannot guarantee at all. However, in order to catch large droplets, finely woven fabrics can actually help capture those large droplets coming out of symptomatic patients' mouths. And it's a lot better than simply letting them cough into the air into the room. I guess that's all I can say about those recommendations for fabric. I would definitely not encourage healthcare workers to wear fabric masks.
Great, thank you. That's really helpful. I got someone snuck in a final question here, if that's okay. I'm going to ask everyone to hold questions at this point. We'll see if maybe we can do a follow-up or find some way to collect questions that people are gathering and maybe provide information. But I want to respect everyone's time, especially Valerie's for who's given us almost 2 hours here. Grateful. So the last question, and we'll wrap up, is asking for recommendations on use of expired N95s for droplet precautions, not as a respirator.
Yes. How quickly and how, like when they're expired, just simply over time, the N95s, I have absolutely no idea how good they those respirators then are in meeting the requirements of that N95. But you're totally right that they would definitely catch droplets. However, like I said, because the HEPA filter material of the N95 is so thick, you still have to wear it with a proper seal. Otherwise, more air will pass through the air leak than through the filter. So it will catch some large droplets, but it will create probably less filtration if it's not fitted to your face properly than a surgical mask, or at least give you no benefit compared to a surgical mask. So wearing it as a surgical mask and to catch large droplets and trying to keep a proper face seal on your face to actually do some sort of filtration as well seems to me like a safe bet, but not wearing it for aerosolizing procedures that really definitely require some proper filtration.
Wonderful. Thank you very much, Valerie. In wrapping up, I want to thank all of our participants today. Thank you all for your interest, your fantastic questions, and for all of the work that you're doing out in communities across the country. Easy for someone like myself sitting here at 10,000 feet and not right on the front lines to talk about the amazing work that's happening, but it's a whole other ballgame with all of you. And on behalf of our association, and I know partners across Canada, really want to thank you all for everything that you're doing in communities, and to do so while also juggling your old households and everything else that's going on. Hope this has had value and will have ongoing value for you. The webinar here, and sharing it with your colleagues. Piotr, thank you very much for working on behalf of the British Columbia Association of Community Health Centres to help recruit Valerie into our efforts here, and for all of your time, and Valerie on such very short notice for pulling together this presentation, for all of your time and your extra time today. We're incredibly grateful, and I hope we'll have an opportunity to connect and work on an ongoing basis and into the future, hopefully not under such critical circumstances. So again, thank you very, very much.
Thank you so much, Scott. It was my pleasure and my honor, really, to help out.
Wonderful. So we'll wrap up, and I'll say thank you and good afternoon and good evening to all of you. Wishing all of you, your coworkers, those in your community and your families, safety, health, well-being over the days ahead, and just a general announcement. Reach out to the Canadian Association, please, if you have any requests. We're trying our best to capture what the needs are on the ground, and how and where we can help and support our members across the country. So please, that's an open invitation. Just let us know what you think we can do, and we'll do our very best to try to move some stuff forward in the next little bit. So thank you, everyone, and here's signing off.